ready. So our next presenter is a beloved CF nurse coordinator at Bay Area Pediatric Pulmonary, UCSF Benioff Children's Hospital, Oakland. In her 30-plus years in the field of CF, DJ Kaley has witnessed the significant advances in care for those with CF and the accompanying and the need for supportive transition programs for youth with CF. So please help me welcome DJ Kaley. She's going to give a very informative presentation. We know it. We love her. Thank you, DJ.
I always say I'm the old war horse because next year it'll be 40 years. and it's actually why I went into nursing. My best friend's brother had CF, and that's what I wanted to do. So we're going to talk about transition today. According to Webster's, transition is the passage from one state, stage, or place to another. So our goal for all patients with CF is to learn about and manage their CF, to successfully transition from the pediatric center to the adult center, and to lead a happy, healthy, successful adult life. We do our stages of transition. We start at age 8 to 10. The next stage is 10 to 12, 13, 14 and 15, 16 and 17, and then 18 to 21. At age 8, we start with teaching them what it means to have CF, to learn how their lungs work, to understand why airway clearance is necessary, learn how the body uses food, understand why salts and fluids are important, to learn the names and basic understanding of the reasons for their medications, and to start taking responsibility for taking their own enzymes. And one of the ways I try to teach the kids about why airway clearance is so important is I give them a gross but effective visual in that lungs are a dark, damp place like a refrigerator, and mucus contains protein like a bologna sandwich. And what happens if you leave a bologna sandwich in the back of the refrigerator for a couple of months? And then they say, well, it gets kind of hard and kind of fuzzy. I'm like, exactly, and that's what's happening inside your lungs, so that's why we want it out of there. We also teach them to understand why some people have CF and some do not. By age 9, we expect them to know the names of all of their medications, the doses, and how often they take it. And by age 10, they need to know why each medication is necessary. From 10 to 12, they still have to remember everything from stage 1. Then they have to start telling us how their lungs work. And they have to remember most of the time to do their airway clearance on their own and not have to be reminded by mom and dad. They need to be able to describe how their body uses food, to take enzymes on their own, and remember about taking more salt and fluids, especially in hot weather. One way that I like to do this with them is when we have visiting residents or medical students. So they come into the clinic room with us, and I actually have the kid teach the med student or the resident why we're asking these questions. Like one of the questions is always, do your poops sink or float? And I say, now you explain to them, why are we asking that question? So that they can tell them and have an understanding of what malabsorption is and why that's important and why we're asking about that. By age 11, we start teaching them about CF and smoking. And by age 12, we teach them about reproduction. At 13, we actually start meeting with them alone. So we first start off with the parent and the kid in the room and just, hi, how are you? And then we ask the parent to leave and we meet with the child alone. And they answer the questions independently. And we want them to with a goal of becoming into the clinic independently at a later age, and to understand why they need to come independently and why they need to come quarterly. Then, after we've talked with the child and gone through everything, then we bring in the parent and review and make sure that the stories coincide. And then we present the final plan for the day and send them on their merry way home. We want them to understand their respiratory baseline and changes. So we want them to know what their baseline daily cough is. Is it none at all? Is it only with treatments, or do they always have some daily cough? We want them to pass performance checks on airway clearance and medicines. So at our quarterly visits, they meet with the respiratory therapist and they go over cleaning and how to use the machinery, as basic as take the nebulizer out of the closet and plug it in. Set the machine up. So we do efficacy scores as to, okay, you're on twice a day hypertonic saline. So in the last 2 weeks, twice a day would be 14 treatments. How many did you actually do? And then they get a score, and that way we know when they need more education as well, because if their efficacy is falling off and they're not doing treatments as regularly as they should, we can then re-educate them, because studies have shown that the more you know about your disease, the more adherent you are to your program. By this age, we hope that they need fewer reminders to do their therapies, that they understand the digestive baseline and changes, that they remain independent with their enzymes. One of the biggest places where they fudge taking their enzymes is at school, because they don't want someone to know, or they don't want to go to the nurse's office to get the enzymes. And so we explore ways of getting around the embarrassment of that. And maybe it is to let them carry their enzymes on their person at school, and we will arrange with the school for that to happen. Or sometimes it's as simple as encouraging them to teach their friends about CF, and that they have CF and what's going on with that. And even for me to go into the school and do a little in-service for their classroom. We want them to learn to use their well plan and sick plan. So at every visit, they get their well plan, which is their daily regimen. And then they also get a sick plan, which teaches them that at the first sign of a cold or a cough, increased cough or mucus, they should double their airway clearance to 4 times a day. And they're to do that for 2 days, and then call me if they're not getting any better, and then we decide on if it's an antibiotic that's needed, or if they need to come into clinic and be seen, or if they need to be admitted. We want them also to understand what testing is done and why. So we want them to know what is the annual testing that is required. Why is an oral glucose tolerance test needed? Why do you do 4 sputums a year? Why do you do 4 PFTs a year? And when those should be scheduled. By ages 14 to 15, we want them to be independent with their airway clearance. We want them to be able to set up their vest or their aerobica and their nebulizer and do it all themselves with just minimal supervision and hopefully no reminding and no nagging from parents. We want them to be independent with enzymes, that they just automatically take their enzymes, that they don't even give it a second thought. We want them to be able to describe the annual testing and the rationale for that testing. And we want them to make healthy lifestyle choices in their friends, avoiding alcohol and drugs, and definitely avoiding smoking. By 16 to 17, we want them to actually plan their annual testing. So we want them to figure out, it's best if I do all of this testing in the summer when I'm off school, so I can spend a whole day doing a pulmonary function and exercise test and doing an oral glucose tolerance test. We want them to describe healthy lifestyle choices, such as eating right and exercising. We want them to start monitoring their medications and their supplies, and to keep track of when they need refills, and to call the CF Center directly for advice. And this is very cute the first time I get the call. It's DJ, I'm old enough now, my mom says I have to call you and ask for a refill. So it's like, hey, great, I'm glad to talk to you. And I just really encourage them to keep up with that and to not be afraid to call me. By 16, we want them to talk with their parents about their basic health plan, the cost of their medicines and insurance options, because these are things they're going to need to know as they go off to college or go off to work. By 17, they should have developed their own list of important qualities in an adult CF center. Between 18 and 21, they should already be independent with all of their airway clearance and medications. They should know the names of the meds, the reasons they take it, the dose, the frequencies for the sick and the well plan. They should be independent with their clinic visits, plan their annual testing, continue making healthy lifestyle choices, monitor their medicines and supplies, and call for their own refills. Call the CF Center directly when they're sick, and secure financial coverage or insurance. Also by 18, it's law, they have to complete an advance directive. So we need them to think about, in the years to come, what they want done in the event of an emergency. College readiness. We always locate the adult CF care options in the area of what college they've chosen. We ask them to determine the insurance coverage for school, meet with the student health center regarding their needs, talk with the disability office about provisions for illnesses and admits, and talk to the CF team to see if they need a, although we don't use this term anymore, tune-up just before leaving for school. We want them to plan with their parents how to get their medications at school, and they need a backup plan in case they run out of meds and need something urgently. For their living situation, they're going to need surge protectors and 3 hole grounded outlets. They're going to need to think about infection control, disinfecting their room before unpacking, checking for mold, using germicidal wipes for all surfaces and drawers, and vacuuming regularly, and determine if their bathroom facilities meet their needs. For prevention, we want them to know what immunizations are required and up to date. They still need to get their flu shot. They need to have the HPV, meningitis shots. They should avoid people with obvious illness and continue to make healthy lifestyle choices. We also talk about their well-being in general at college, and that they should consider their CF as a 4-unit course and plan on finishing school in 5 years, not 4. And they should plan 1 fun, low-stress class per semester or quarter. So we know that their basic CF airway clearance takes about 2 hours a day. I think Dr. Moss showed that. So, and when they're sick, it's double that. So we need them to realize that their CF care is like a 2-hour class every day, 7 days a week. We want them to exercise regularly and eat healthy, to plan to get their daily caloric needs in, to consider a small refrigerator and microwave for their room, and to weigh themselves weekly and get a scale for their room. Preparing for transition, we also work with the parents and adult family members. We are starting at age 8 and following the transition guidelines. We work with the child to take on more responsibilities, and part of that is also in encouraging the parents to step back and let them take more responsibility. At age 13, we support the child seeing the team alone at first, and then we bring the parent in. We determine age limits and terms of coverage with your insurance and start talking about this with the 16-year-olds. Determine how insurance handles referrals to the adult center. asked to connect with other parents who have successfully transitioned their children, and rely on the CF Center team for support. With the adolescent and young adult, we want them to gradually assume all aspects of their care, keep their records organized, work with the dietitian to maintain appropriate weight and nutrition and to make plans for how to do that in college. Asked to connect with another young person with CF who has successfully transitioned to one of the adult centers. Work with their parent to understand how insurance coverage works. List questions for adult health care practitioners. Work through the transition booklet and rely on their parents and the CF team for support and encouragement. As the team, we follow the transition guidelines. We encourage the patient to interview adult care team members and choose the best fit. If they're staying around here for college, we're very blessed. We have 3 adult centers in the Bay Area. So we tell them, hey, go check them all out. See the facilities, talk to the people, see who you fit in with the best. If they're going away to college, we look up what the center is closest to their college and tell them. If there are a couple, again, we say go investigate, see where you feel like you fit in the best. We encourage them to come to clinic visits prepared to talk about their health, medications, and therapies. And we remind the patient and the parent that the CF care teams support. So we have, a social worker, the dietitian who can address various aspects of their life. Some of you have more support than that, and that you might have a psychologist on your team. And if you do, I'm very jealous. We also contact the adult center with records to assure a smooth transition. So how do they know they're ready? They can take responsibility for their own care. They're able to get themselves healthy meals, make their own appointments, get refills and supplies, and identify a change in health and to call the CF team. They're able to discuss their health history and make a plan with input from the team. They've met all the goals in the transition workbook, and they have a plan for the future. The transition binder starts out at age 8, and the tasks are reviewed at every visit. And then there are also individualized plans. So we have this general thing for everybody, but then we individualize it to each kid depending on their needs and how they progress along the transition workbook. We have a partnership with CPMC, Stanford, and UCSF. There's a team approach from the doctor, the nurse, the dietitian, and the RT. There's private insurance, or GHPP, which is CCS for adults, for those of you who have CCS. When they're 21, they qualify for GHPP. And in general, you don't transition anyone who's medically fragile. So anyone who is in imminent death, you wouldn't transition to the adult team because you don't want to separate them from the team that they've been used to all their life. Fortunately, that doesn't happen much anymore. Everybody grows up and goes on to the adult team, and we don't have to worry about that. And even though it's hard to see my little fledglings leave, it's a very proud day for me when they graduate and go off to the adult team. Great successes are when the patients call and say how well the new center is doing in caring for them, and the new center calls to say how well the patient is doing. And fortunately, we have had no nagging failures thus far. Questions?
You mentioned having the kids carry their own enzymes. My daughter is 5, and she's doing that in kindergarten, but she's going to go to a new school, and they're having an issue with that. Is that something, a letter or something that I can ask for the doctor, and is that acceptable in majority of the schools? I don't know.
Yes, there are several ways to go about that. The nurse or the social worker can contact the school and talk to them about it. A letter from the doctor supporting them carrying their enzymes on their person can help as well. What we encourage is either getting an IEP, individual education plan, or a 504 plan, because then this alerts the school to there may be times when they're going to be absent for a few days to a few weeks because they're sick, and that they're going to need extra help in making up that work, and also accommodating their medications.
Can you explain a little bit about those plans? I understood they were only for public schools, or are they for private education as well?
You know, I don't know the answer to that question.
Pretty sure that private schools don't have to.
Private schools don't?
Buy an IEP, but most of them do it.
Okay, I know I have written letters and gone to IEPs at private schools, but
You have the checklist and the criteria that they can meet, and I can tell you, my daughter is transitioning, literally, they're going to pry her fingers from her wonderful care team at the pediatric side because she doesn't care that Kung Fu Panda is on in the waiting list. She loves her team. And that's been really clear. It's been something they've talked about through the years. I'm curious, what is the impetus at your center when a teenager has met all this criteria? They're clearly capable of transitioning. Are you waiting for them to self-identify to say that they want to move on? How is that discussion? How does it take place, this discussion?
yes. Part of it is insurance driven, because if you have CCS, California Children's Services, you can stay with the pediatric team until you're 21. And some adult places don't take CCS. So therefore, you're stuck with us. Otherwise, we find that some are ready when they go off to college. And especially if they're going away to college to another state and they're going to go to the adult center in that other state, that then when they do move back to the area, they just automatically go to the adult center and do not come back to us. Some are mature enough and request, you know what, I'm ready to go and be with the people closer to my own age. But because, like in the old days, we used to say CF was womb to tomb. You know, they were just with us all their lives, and so they don't want to leave their team. So they, most of them, put it off to the very last minute.
Can you comment on the college situation? My experience has been that for many families and the patients themselves, when they're contemplating going off to college, the living situation is a big issue. And they are often asking for either an individual room or a room in a suite so they have their privacy. They can be embarrassed about the noise from their airway clearance and so on. Any comments?
Absolutely. I write a lot of letters about this. So we do encourage them to have probably just one roommate or none, because the vest can be pretty loud and the nebulizer machine may or may not be loud. And so we do know that that can impact the study habits of a roommate. So we want them to carefully pick their roommate on that respect, and also the bathroom issue. So I write a lot of letters about how they need to have their own bathroom suite with their room, or that sort of thing.
So DJ, I have a question about insurance, and I don't know if it's changed or not, but regarding CCS and GHPP. 25 years ago, when my daughter was on CCS, there was a little-known clause that once parents reached that income cap, they could actually put their child into GHPP. So do you know if that still exists? Because a lot of parents
aren't
It
aware of
does, and
Okay.
actually, fortunately, I was the nurse in LA for 20 years before I came up here, so I worked, and because at that time, we did still have our adults, so I worked very closely with GHPP as well, and I learned that. And I find that even our social worker up here, DJ, why are you referring them to GHPP? They're not adults. And I said, doesn't matter. If they make over the threshold for CCS, they might qualify for GHPP, so we need to look into that.
This is just actually a comment, then I promise I have a question. But in terms of the college and your question about private versus public, I can say when my daughter was going to college, that was the most important thing we did in advance, because the private universities she was looking at, many of them said flat out, we cannot accommodate. They have their limitations. Public universities, however, are bound, and it was pretty remarkable how many accommodations she received to help her thrive as a student. So I just put that out to other parents. And then this may not be related to transition, but I keep hearing mention of exercise tests. And that is not, it's not something that I think my daughter has had. And I'm just curious, is this a new trend? With all this emphasis on the importance of exercise, what is done at your center what is that test? What are we?
I wouldn't say it's necessarily a new trend, but I think that the foundation is focusing more on it. We've been doing what used to be called the 6-minute walk test for years. And then as data comes out and shows how exercise is important, we've expanded that to do a full PFT with an exercise test once a year. Thank you.